So like Dr. Ruchi has said, when a tumor comes from the operation theatre to the pathology lab, we have to decide whether it is actually an inflammatory lesion or a tumor. Then the next question is it benign or malignant? If it is malignant, we need to grade and stage it. And after we know whether it's either benign or malignant, whether it's an epithelial or a mesenchymal tumor, then whether it's primary or metastatic, and our final diagnosis rests on light microscopy. And in case light microscopy is not confirmatory, we have to resort to special investigations, which is immunohistochemistry. So basically, immunohistochemistry will help us to localize the type of tumor. It does not help us to tell us whether it's benign or malignant. That should be very clear. So by light microscopy, by histopathology, we are able to tell you the type of lesion it is and whether it is benign or malignant. Immunohistochemistry will only tell us what type of lesion it is. So in the orbit now, we can have primary tumors, which are from the various structures in the orbit. The primary tumors can be mesenchymal tumors or they can be epithelial tumors. Epithelial tumors are mainly from the lacrimal gland. And we can also have extranodal lymphomas. Then the secondary tumors can be direct extensions from the adjoining structures, or they can be lymphoproliferative disorders which have now presented as lymphomas in the orbit, and then we can have metastatic tumors. Now this is the spectrum of the orbital lesions in an analysis we have done at our center. So you can clearly make out that secondary metastatic tumors are fairly common in the orbit, and they accounted for about 20% of the lesions. And following that, the lacrimal gland lesions, the vascular tumors and the benign mesenchymal tumors are round about 15% each, and the lymphoproliferative disorders are around 8%. The malignant mesenchymal tumors are pretty low. They are accounted for just about 4% of the lesions. Now coming to the primary orbital tumors, I'll first focus on the lacrimal gland tumors. The commonest lacrimal gland tumors are the pleomorphic adenomas. They account for 76% of the lesions. And the next common are the adenoid cystic carcinomas. And the rest of the malignant, the lacrimal gland tumors are not so common. So how do we diagnose a pleomorphic adenoma? The diagnosis starts at the grossing table. You can make out that they are pretty well circumscribed lesions and they've got a glistening appearance. And the glistening nature is because they have a component of the mesenchymal element. So they are also called mixed tumors. So you can see very clearly they have the epithelial component, which is ductular, and then the mesenchymal component, which is caused by the myoepithelial component, and the cell of origin is the ductular cells. Even though they are benign tumors, they are known to recur, and they can even result in malignancy later on. Now coming to the next common is the adenoid cystic carcinoma. As you can make out, when we are grossing these tumors, as compared to the pleomorphic adenomas, they are not so well circumscribed and they are more solid appearing. And microscopically, there are 5 histological types. And why do we need to histologically type the adenoid cystic carcinomas? Because the prognosis depends on them. See, in most of the adenoid cystic carcinomas have this classical Swiss cheese pattern. So these have a better prognosis. Whereas the solid pattern, that is the basaloid variant, has got a worse prognosis. And the another common thing about adenoid cystic carcinomas, which Vishnu had talked about, is the perineural invasion. So we as pathologists should look for perineural invasion as well as vascular invasion, because that will make the prognosis worse for the patients. Now then there are rare lacrimal gland tumors. There are tumors like mucoepidermoid carcinomas, then epithelial myoepithelial carcinomas. It is very important for us as pathologists to differentiate these from the adenoid cystic carcinomas, because the prognosis in these tumors is much better than adenoid cystic carcinomas, and we have to resort to a panel of immunohistochemical markers. Now coming to the staging in lacrimal gland tumors, although we usually do not stage lacrimal gland tumors, it is important that we start staging lacrimal gland tumors. And the staging is based firstly on the size of the tumors. If it is less than 2 centimeters, they are low grade. They are T1, and if they are more than 2 to 4 centimeters, it is T2. And if bone invasion is present, they are called as T3 and T4. And then the low grade and the high grade variants are also there depending on the histology. pleomorphic adenomas which become malignant come into the low-grade category, whereas adenoid cystic carcinomas are regarded as very high-grade tumors. So histopathology is very important for further management of lacrimal gland tumors. Now coming to the vascular tumors, they have already been discussed. They account for about 15% of the orbital tumors, and on the grossing table we see them as very darkly stained, violaceous colored tumors, well circumscribed, and they got a very spongy appearance. And you can make out the vascular channels, they are thick walled. You can see the muscle in the walls. In contrast, lymphangiomas, which Dr. Ruchi talked about, they have got irregular vascular channels and very thin walled. Mangiopericytomas now come into the differential diagnosis of mesenchymal tumors, and they are very erratic tumors. Like on histopathology, we will not be able to tell you how it's going to behave. One particular mangiopericytoma might have no mitotic figures, but it might metastasize. Another one might have 5 mitotic figures, but it might remain benign. So it's very important to follow up these patients. They have very unpredictable behavior. So this is how a mangiopericytoma looks like. Basically, it's a spindle cell tumor. When you see these vascular channels in between, we call it a mangiopericytic pattern. And on higher magnification, you can see these are the vascular channels. This is the typical staghorn pattern, and they stain positive for SMA and focally for CD34. And most of the benign ones are supposed to have mitosis less than 4 per hyperfield. Now, a very important differential diagnosis for pathologists is the solitary fibrous tumor, which mimics hemangiopericytoma, but it has got a much better prognosis. So how do we differentiate it from hemangiopericytoma? See, on gross examination you can see they are not so violaceous. They are more fibrous appearing. The reason is because on histopathology also we have these bands of fibrous tissue. And the histochemist, we have to resort to immunohistochemistry, and you can see the CD34 stain is diffusely and very strongly positive in solitary fibrous tumors, whereas in hemangiopericytomas it is focally positive. Another marker which helps us is BCL2, which is more positive in solitary fibrous tumors. So we should, as pathologists, be very careful, as SFTs are quite often undiagnosed. Now coming to the lymphomas, which Dr. Ruchi had covered. In adults also we can have non-Hodgkin's lymphomas, which can present as primary masses or as a result of the secondary, and most of them are low-grade lymphomas. And immunohistochemically, most of them are B cell type. These are those of the maltoma type or the low-grade extranodal lymphomas. They have a good prognosis, but they need to be followed up for systemic spread. Now coming to Langerhans cell histiocytosis, which Dr. Ruchi had touched upon, this is once again a systemic disease. And like Dr. Vishnu has said, we need to do a systemic workout and see whether other parts of the bodies are involved. And microscopically, we have these typical Langerhans cells, which are positive on CD1A and S100, and this is the electron microscopic view, which is showing typical Burbeck granules. This is confirmatory for Langerhans cell histiocytosis. Now coming to the smallest portion of the mesenchymal tumors, which are a big headache for the histopathologists, because all of them look like spindle cell tumors, and we have to use our acumen and decide which of the various malignant tumors is. Though actually for management point of view it might not be so important, but being pathologists we are not satisfied till we know the cell of origin. So most of them, like I said, are spindle cell tumors, and we are trained as pathologists to diagnose by patterns. Like storiform patterns are for fibrous histiocytomas, but it might not be correct. You might have other tumors like mangiopericytomas which have a storiform pattern. So there's a lot of overlap in the patterns. So ultimately we have to resort to immunohistochemistry, and as I told earlier, malignancy we should diagnose only by cytological features. So this is the panel of immunohistochemical markers which we can resort to. Vimentin will be positive in all mesenchymal tumors. Desmin and actin are smooth and skeletal markers. S100 protein is for neural tumors like schwannomas, neurofibromas, and CD34 help us to diagnose hemangiopericytomas and solitary fibrous tumors. This is the immunohistochemical stain to show Vimentin positive which is positive in all mesenchymal tumors. So basically it helps us to differentiate from epithelial tumors. This is a stain for Desmin, which helps us to characterize rhabdomyosarcomas. Now fibrous histiocytomas Earlier in pathology, there were a lot of tumors which were diagnosed as fibrous histiocytomas, but now it is said the most recent concept is this is the rarest tumors, and it is because pathologists can't make can't subtype the mesenchymal tumors, so we dump them as fibrous histiocytomas. So actually, they are not very common, and it is a diagnosis by exclusion. A case which is S100 negative, CD34 negative, most of the markers are negative. But it is Vimentin positive, which has got a characteristic storiform pattern. Storiform pattern means a cartwheel pattern. That is supposed to be a fibrous histiocytoma. They can again be benign, locally aggressive or malignant, and this is based on the presence of the mitotic figures. Now coming to the peripheral nerve sheath tumors, they are quite common at our setup, and they are often misdiagnosed even as inflammatory tumors because they are known to present as marked cystic degeneration, and the cases which are diagnosed as cysticercosis or hydatid cyst also by the ophthalmologist, and they really don't believe us when they give the diagnosis. I've had ophthalmologists who say, ma'am, you please look at the slide once again. Is it really a schwannoma? So I think as ophthalmologists, it's a big diagnostic dilemma. But fortunately for us as pathologists, it's quite a simple affair because they are spindle cell tumors, and they've got a very typical S-shaped nucleus, these neurofibromas, and on S100 they are positive. So when we are seeing a neurofibroma, it's a neurofibroma, it can't be an hydatid cyst. Then neurofibromas can also be plexiform neurofibromas. The differentiation in this case, unlike the diffuse neurofibromas, is we have these bundles of nerve fibers surrounded by a perineurium, and we have to investigate, like Dr. Vishnu said, for von Wetling-Host's disease. And schwannomas have got the typical Antony A and Antony B areas. They are encapsulated. These are the vertebrate bodies in which you have palisading of the nuclei, and these are the Antony A areas, and these are the loose Antony B areas. They are also S100 positive, and these are usually associated with neurofibromatosis type 2, and which you should look for meningiomas associated and schwannomas. So optic nerve gliomas have been already covered by Dr. Ruchi. The next important tumors are the meningiomas. They have got typical Samoma bodies, and the EMS stain is positive. Smooth muscle tumors are very rare. Fibroosseous tumors are also very rare. We have occasional cases of fibroblastic, fibrous dysplasias, in which we have this woven bone, and they lack the osteoblastic rimming. In contrast to the fibrous ossifying fibromas, they have a lining, osteoblastic lining. Chordromas are cartilaginous tumors. They are also very rare, and we have a whole lot of rare orbital tumors which I will not be covering. Some of these tumors which will be covered by Dr. Kashyap and Dr. Bhavna in the next session. Now finally, after all the panel of immunohistochemical stains, if we are unable to diagnose, many of the tumors we say it is an undifferentiated or a poorly differentiated malignant mesenchymal tumor. We are unable to classify it. But however, we should still try and grade it so that they can be given radiotherapy or chemotherapy, and this is based on the recent AGCC staging, which is based on mainly on the size of the tumors. And the cutoff is 15 millimeters between T1 and T2. And finally, now the metastatic tumors and the secondary tumors, they form a big chunk of 20% of the tumors. We have tumors from the eyelid, from the conjunctiva, from the intraocular spaces, as well as from the meninges. They all infiltrate the orbit. In children, the neuroblastomas are very common. Dr. Vishnu talked about it. These are diagnosed by small round cell tumors, which are positive by neurofilaments. And adults, intraorbital metastasis is much rare. Intraocular is commoner. And these we again diagnosed by a panel of immunohistochemical markers. CK helps us to diagnose epithelial malignancies. HMB45 is for malignant melanomas, and neuroblastomas is neurofilaments. Thank you.